Assalamu alaikum. Today we'll talk about the Hall technique. وما أدراك ما Hall technique. So the Hall technique is one of the restorations which is very common and recently being used in pediatric dentistry. Or we call it the novel method in restoring the caries primary molar. So this is our title today. So we're going to have a discussion about the Hall technique, and then we'll have a demonstration there on the technique of the Hall technique, and hopefully it will be very helpful for you. And please tell me whatever question you have, and I'll try to answer all the questions. And if I couldn't, you can anytime ask me at any point with any ways. Okay, so let's have a look at this presentation you can see here. So we have this condition where you have restorations, buccal caries, mesial caries, distal caries, or restoration with recurrent caries. On the other hand, again, you will see carious teeth, hypomineralized sixes, arrested cavities. So both have dental caries or early childhood caries in the primary dentition. So we have dental caries condition here and dental caries condition here. But if you look into the next slide, the first case has been treated by giving the local anesthesia, drilling. Yeah, local anesthesia was given, drilling and filled and then crowned. On the other hand, these teeth were crowned only with no any, especially for the sixes. These teeth were not given any local anesthesia. There was no any preparation. There was no any caries removal and only crown restoration. So we have two approaches of the same. Hopefully, by the end of the presentation, we'll reach to the conclusion that if both ways have the same end result and success rate. So the future direction in the practice of the pediatric dentistry in general is to improve the care for the our patients. But we need to always, whenever we do any treatment, or when we have any kind of restorations or any treatment plan, we need to remember that it should be through the evidence-based pathway of the care. We cannot do any treatment for any child with any treatment which is not evidence-based or approved. So let's have a look now. So if you consider that you have this mountain of the evidence, and in this mountain of the evidence you can see that the most the powerful or strong evidence that we can get from the literature are from the systematic reviews and meta-analysis. So let's have a look into this. So we translate the good science into the good clinical excellence. So whatever we do in the treatment, again, it should be evidence-based. So why I'm talking about this? Because I want to show that the Hall technique is an evidence-based treatment plan, and it's added now in the toolbox of the pediatric dentistry. So here, let's talk about what are we going to achieve today. We're going to addressing the myth of the minimal intervention, which is the biological techniques, and where is minimal intervention, which is no drilling approach, appropriate, and where is it totally inappropriate to use the Hall technique or biological techniques. So I'll start with giving you an example of an uncooperative or pre-cooperative child. Pre-cooperative child is a child who is not able to cooperate with you because of his age, especially in the very young ages, like 3 years old. We call them pre-cooperative because the cooperation is not a factor in these patients because they are too young to cooperate. So in pre-cooperative child and uncooperative child, I'll give you all the treatment plans. Patients came, if you can get closer, patients came with having dental caries into the dentine, but still they have a clear band of dentine everywhere. So the caries affecting the dentine, but still the caries have not reached to the pulp. The teeth are asymptomatic. Patient has never complained of any pain. There are no any sepsis. There are no any infections, and there is no any pulpal infection yet. So what only you can see the caries which are affecting the teeth and not reaching the pulp. So what treatment options we used to have in general for pediatric dentistry? If the patient is very young, the treatment options, we have usually 3 options. First one, which is doing under general anesthesia, which is the last option actually, and then the option if the patient is cooperative enough or patient can understand about the 6 and 7 years old, we might do some sedation or in a nitrous oxide sedation to do the restorations. Or if the child is completely cooperative and you have the cooperativeness of the child to do the treatment, you might do the treatment in the dental chair. So these were the main three areas of the treatment or our treatment plan options, which was doing the normal treatment under local anesthesia in the dental chair, or if the patient is uncooperative, you might try the nitrous oxide inhalation sedation, or for very uncooperative and pre-cooperative children, we used to do the treatment when we still do on treatment under the general anesthesia. But let's have a look into this case again. You have imagine that you have a very young child, 3 years old, with all these cavities coming to you, and patient is pre-cooperative. So the only option maybe at that time is to do the general anesthesia. But why? Because imagine that you want to give local anesthesia for every quadrant or for each tooth and do the cavity preparation and restore the teeth with the composite, and knowing the retention rate of the composite with the primary dentition, especially in class 2s, is not that high. So you will keep the patients undergoing this trauma from the local anesthesia and treatment for a very long time. And then the idea of the whole crown came in. And whole crown saved this patient. This is the case of the whole crown. It's all whole, so 8 teeth were restored with the whole crown. When the idea of the whole crown came, so we saved the child from going under general anesthesia, and we saved the child from having the traumatic experience or the traumatic impact from the giving local anesthesia, drilling the teeth, caries removal, and the pain during the procedure. So this patient we saved them from all these negative points, and at the end result you can see that this patient we restored all the teeth with the crown, I'll show you later, this is a 2 years follow-up of the same patient. 6s are not erupted here, and you can see the 6s erupted. So this whole crown basically saved the patient's life, saved him from the general anesthesia and traumatic experience from the dental procedure, and having these sound teeth for a very long time. Okay, so also consider the failure of the dental treatment under general anesthesia. So because many of the cases that we do general anesthesia, still the patients might come back with the relapse, we call it relapse, or new caries lesions. Let's look why usually these patients come back after general anesthesia and still they have caries, new caries lesions. One of the reasons is poor parents' compliance and unfavorable eating practices, and the third is unsupervised oral hygiene practices after dental rehabilitation under general anesthesia. So whatever of treatment options we talk, still the prevention is a key in any restorative treatment and options. If you look at this picture, you have a house which is burning from inside, and if you change the windows, the burning windows, you will not solve the issue. So prevention is just when you have a burning house, you need to stop the fire inside the house and not changing the windows. If you do the restoration, you restore these windows without stopping the fire, which is a poor oral hygiene and no prevention, you will not resolve the issue. So, replacing the windows in a burning house, which is no any benefit for you, the child will not get any benefit, so prevention is the key of whatever restorative options I'm going to talk to you today. So hard technique is one of the options, but I want to emphasize the prevention as a key factor for any restorative option to be successful. Okay, let's have a look at the ecological system of the dental caries. This is the updated ecological disaster or the system of the dental caries. So many factors now recently has been included in the dental caries, and as you can see, one of the main factors is the sugar, and you have the microbes, and you have the diet and frequency and fluoride. So by looking at these, So you might imagine that if you stop one of these factors in the dental caries process, you might stop dental caries actually. So by having a buffer, stopping the sugar reaching to the bacteria, bacteria cannot reduce the pH of the saliva to cause demineralization and cavities. So by altering this ecological system of the dental caries, if you alter it, you will stop, or you might remineralize. So you will either you arrest or remineralize the dental caries. So let's have a look into this, because the whole technique is going to work by changing this ecological system of the dental caries. So we cannot manage the dental caries without managing the ecology. So first we need to manage the ecology of the dental caries. So where are we now in pediatric dentistry? We have the best CBCT scans, we have the general anesthesia, we remove the supernumeraries, we do surgeries, we have sedation, we have noise restorative or aesthetic restorations. These are the zirconia crowns. So basically we have excellent techniques and materials available as never before. So we have all these materials. Now, how we will use it? So in general, we need to have a look at the child as a child. We need to treat the child as a child and not looking at the tooth only. So by a whole technique, it has a psychological impact, a positive psychological impact on the children as well. Why? Because by reducing the side effect, or by reducing the trauma from the local anesthesia, and by reducing the trauma from the drilling in very young ages, this will have a good impact in the future of the child, which will make him accept the dental treatment in the future. So what is the biological management of the caries? So it's a minimal intervention, or not, it's no drilling or minimal drilling approach. So let's have a look at it. So the biological approach, it aims to reshift the metabolic balance within the dental biofilm, promoting either remineralization and or arresting the carious lesions. So that's the idea behind the whole crown. By the whole crown, so because we are not removing the dental caries from the cavity. If you have a cavity which is asymptomatic, and it's not reaching to the pulp, and it's not causing any like dental sepsis or any like toothache to the dentition, then you don't need to remove it if you change the ecology. If we think back to the ecological system of the dental caries, if in any point you stop that ecological system, you might stop the dental caries either by arresting it, or if it is very initial, you might remineralize it by having some fluoride enrichment of the surface. So basically that's an idea of the whole crown. Yes, we are not removing the caries in the whole crown, in the whole technique, the stainless steel crown. We don't remove the caries, we don't give local anesthesia because it's atraumatic restoration. But we need to understand, if you understand the ecology of the dental caries, then we will understand the biological approach which we are doing by the whole technique. So basically, either we remineralize the dental caries if it is initial, or we arrest the dental caries in the future by having the effect of the fluoride from the GIC. So look at this picture. Many dentists in many kind of the world, they had the same concept of doing an atraumatic restoration for children. So having an atraumatic but with a poor quality, it won't help, because these patients, if you look into this restoration, these are all GIC placed because the patient was uncooperative, because the patient was very will not allow or accept the ideal dental treatment. This patient had all GICs, which with the recurrent caries, retained roots, pulp most probably infected, and I mean, it's a disaster. It's a big X to this kind of restorations. No one does this kind of restorations anymore, because although they are atraumatic, but they are not ideal. These are only temporary restorations, only for not more than 1 year, not more than 1 month, because this is a rubbish restoration treatment. So ART is top of the restorations, but it discriminates use of the glass ionomers because this is not a final restoration. So don't take the concept of the atraumatic restoration by doing a GIC. Okay, so the key factor or key of the success of any biological challenge, the biological management of the primary dentition is the pulp. We need to diagnose, we have a good diagnosis of the pulp, and we need to make sure that the pulp is healthy before doing any putting the crown, which is the whole technique crown. So the key factor is to have a proper diagnosis of the pulpal status. How can we achieve that? You need to have a clinical factors. You need to have a look at it with the signs and symptoms of any substance of any toothache, and at the same time you can have a look at the radiographic features of the tooth, and you need to exclude any kind of furcational involvement or root resorption, any radiographic signs that will indicate that there is pulpal involvement. So in these cases, pulp should be healthy and reversible and not irreversible, which will end up having an abscess and get necrotic. So how can we make sure for these teeth are indicated for the biological technique of restoring the teeth? So the main challenge of this is having a good pulpal diagnosis before doing any final restoration, which is a whole technique. So you can see here, deep lesions, they are not associated with any pulp. You can see deep lesion here. Still you can have an intact band of dentine here, and there you have an intact band of dentine here. So all this, you can see all the teeth are affected. All the primary molars are affected by the dental cavities into different extents, but none of them has reached to the pulp yet. So radiographic appearance here shows that these teeth most probably are healthy. Pulp is healthy. It's not really infected by having a look at the furcation and the extent of the dental caries. And always we need to make sure that we have an intact band of dentine between the cavity and the pulp tissue. So can a biological approach avoid need of the pulp therapy? Let's have a look now. So a new biological approach, which is called the whole technique. So basically with the whole technique, we are looking to it's a biological approach. So this is the same case of the previous x-rays. So we found that radiographically the teeth are fine. We have cavities occlusally and interproximal. They are not into the pulp. We have a clear band of the dentine. Patient have never complained of any kind of pain or sepsis. So we are, from the signs and symptoms clinically and radiographically, we are very sure that these teeth are healthy, and the pulp is healthy, and there is no any infection or sepsis. So what happened then? We have biologically restored these teeth. So you can see the cavitated teeth here restored with the whole crowns. All were restored with the whole crown. Whole crown basically is a stainless steel crown. So basically we did not do any preparation. We did not remove any caries. We did not give any local anesthesia, and we have just covered the teeth with the stainless steel crowns to protect the teeth and to stop the carious activity and arrest the cavity and or demineralize the cavitated lesions in these primary molars. So the whole technique. What we are talking about, the whole technique or the biological approach, what does it do actually? It seals the dental caries. So basically we seal the dental caries into the tooth by the means of a stainless steel crown and its cement. We use the GIC cement, which has fluoride in it. So we hope that with the fluoride in the GIC cement, we have some arresting of the dental caries. And we don't have any caries removal. We don't remove any caries. We don't give any local anesthesia, and we don't do any tooth preparation. So it alters. So let's go back to our previous the ecological system of the dental caries. So it alters the carious lesion environment to the no longer favor cariogenic biofilm progression. So still the cavity might stay there. The caries it might be there into the cavity under the crown, but it will get arrested. Because if no sugar and if no sugar or no any starch reach to the bacteria to reduce the pH in the cavity, so then we don't have any kind of progression of the dental caries. Okay, no questions so far? Yeah. Okay. So, if you want to read more about the whole technique, you have this user manual from the University of Dundee. You can access it free from the Google, or you can get it from the University of Dundee manuals. This is the manual from the University of Dundee because it's first initiated in Dundee. So you can have the whole technique manual. It has all the indications, contraindications, and the details of the technique about doing the whole technique in the primary dentition. You can access it free. So let's talk about the whole technique now, the procedure itself. So as we say, for the whole technique, we don't have any caries removal, we don't need to give any local anesthesia, and we don't need to do any preparation. So let's go back to the conventional stainless steel crown placement. How would we do? We anesthetize the tooth, and then we do the occlusal preparation, mesiodistal preparation, and then we choose our crown and we cement it with the GIC. And now for the whole technique, we don't give any local anesthesia, we don't prepare the tooth, we don't remove any from the dental caries, and we just need to place the orthodontic separators. These are the separators. We place them between the teeth. This tooth, for example, imagine that it has mesial and distal cavities. D1, so D1 cavities, which is initial to dentine, or D2, which is away from the pulp. So this teeth, for example, if it has dental caries, we place the separator, one mesial and one distal. Okay, we need to wait from the time that we place separators. We need to wait from 7 to 10 days, not more than that, maximum 7 to 10 days. So you can have 1 day, you can have 2 days, but not more than 7 days, 1 week. So you put the separators in place, and then you call the patient next visit, or if you have done it in the beginning of the week, at the end of the week or after 2-3 days, you will call the patient back, and you see this spacing between the teeth. So once you have this spacing, and then you will choose the correct size of the crown. So once you choose the correct size of the crown, it's very tricky to find the exact size or the proper size. By training, you will get used to how to choose your size, because on the trial you cannot push it fully in because you have a spacing. Tooth has not been prepared, and you are trying your crown now. So in the trial, we cannot push the crown fully in because it might get stuck and it's hard to remove it, and sometimes you need to section it. But you need to have an idea. If you push it further, it will go in deep into and it go 1 millimeter subgingival. Once you tried your crown, you select your crown, you fill it with the GIC, eluting cement, and then you cement it, and then you remove the excess cement, and you make sure that's fully seated, and then you will let the patient bite, and this is how it will look like. So in general, once you create a space mesiodistally or mesial and distal to the tooth, you create a space, you will choose your correct size of the crown, and then you place your crown after creating the space and using the eluting cement GIC. Okay, so how can you do that? Because you have not done any occlusal reduction for these cases. You have not done neither mesiodistal nor the occlusal reduction. You have the tooth fully intact, no any reduction. So once you place the crown, definitely there will be a higher point. So the teeth, because you have the tooth and you have the crown on top. So definitely there will be the tooth will be higher than the adjacent teeth. I'll show you now a couple of slides. This open, or it might cause, or we call it open bite. This open bite will reduce within 10 days or 10 days to 2 weeks. So the preferable the interval between each visit, if you have to do, like, if you go back to the crowns that we did 8 crowns for our patient here. So we did not do the crowns all in one time. So, and the guidelines or manual, they suggest that, and we always do that, to do the crowns in a contra-angle side. So if you do a crown on the right side, you can do another crown the same with it, but make sure it's on the other side. So you cannot have two opposing crowns cemented on the same visit, and you cannot have two adjacent crowns because it's very hard to create a space for two crowns adjacent to each other. So you cannot have two adjacent crowns cemented in the same visit, and you cannot have two opposing crowns cemented on the same visit. You can have one crown here on the top and one crown here on the same visit, and then you wait for another 2 weeks and you do the other two, and then you want to wait for another 2 weeks to do the other two. So that's the very important point about the whole crown, the interval between the visit. So no opposing, no adjacent on the same visit, and make sure that you have a 1 week minimum of 1 week to 10 days, maybe 10 days, but much better. So you need to evaluate before placing. So once the occlusion settles, then you can go for the another sets of crowns. So here it shows you another case. There was mesial and distal and occlusal cavity. We placed the separators. Patient came after a couple of days. We removed the separators. Here you can see the spacing between the teeth, and then we choose the correct size of the crown. We cemented, and you can see the open bite here in this picture. As you can see, this is immediately after cementation of the crown. You can see the bite has been opened. This open bite will stay for like around 2 weeks, and in 2 weeks time this open bite will settle and the occlusion will go back to normal. This is very common in the pediatric patients because their bone is too soft, and even during the GA, after doing the GA, we cannot have the occlusion check because it's completely different than the adults. In adults, usually we check the occlusion even after doing composite restorations. We do still check in pediatric dentistry, but it's not a big deal for us if we have a small high bones or we have a higher stainless steel crown, because pediatric or children's bone is too soft and they accommodate or these changes in a very short time. So what are the indications for the whole technique? So there must be no sign and symptoms of the pulpal movement, and there should be a clear band of the normal looking dentine between the pulp and the caries lesion radiographically. So as you can see here, there is clinically there is no any sepsis. Patient has never complained of any kind of pain, and there are cavities which is away from the pulp, and at the same time you can see that you have a clear band of dentine between the caries lesion and the pulp. So indications, the best indication is for the proximal or class 2 lesions, cavitated or non-cavitated. So cavitated definitely we need to restore. If not, for non-cavitated, usually we do for if you have a radiographic lesion which is still in the enamel, but the patient is at high risk, special need patients, those who cannot come to the clinic regularly. So if you are doing like restoration, so as a permission, so if it is non-cavitated, you might do, but cavitated definitely we do. And studies have shown that the class 2 restorations in the primary dentition, whatever if you do composite or any kind of restorations in the primary dentition, class 2, they don't have that much of success rate because of their anatomy. And if you have class 1, cavitated or non-cavitated, in general, class 1 are easy to restore and they have higher success rate. So if you have a class 1 lesion, you can easily restore it with the composite, and they have a higher success rate than class 2. But here it comes in between that if the patient is cooperative to allow you to have the rubber dam in place and do the restoration under the good moisture control, then you can go for a composite. But if you don't have a good like cooperative child or very young child which will not allow you to do the proper composite restoration, in these cases the whole technique is very helpful because you don't need any child cooperation, you need very minimal child cooperation, and at the same time you don't need that much of the kind of moisture control. You don't need any moisture control. We are using GIC. So in which cases we cannot use or contraindicated to use the whole crown? In case that we have irreversible pulpitis with the signs and symptoms, or patient complained of the pain, or there are some abscess or sepsis. So this teeth means they are necrotic, or they will tend to become necrotic. Or you have radiographically, you see the pulp is involved for cation radiolucency, preapical radiolucency, root resorption, and also teeth which are unrestorable or near exfoliation. Even if we don't do a whole crown on a D, which in the child who is 9 years old or 9.5, because expected to within 1 year or less than 1 year to become exfoliated unless it is necessary. So unrestorable teeth or near exfoliation, you might not do whole crowns. So with the whole technique, the process of the fitting crown, it is very quick because no any restoration needed, no any caries removal, tooth preparation and local anesthesia needed, and it's non-invasive, so it's child-friendly dental procedure. The crown is seated over the tooth with no caries removal and preparation and no local anesthesia. So let's come back to the idea that we said that there will be an open bite, which is temporary open bite because the crown will be higher because we have not done any occlusal reduction. Yes, there will be an open bite, and according to the Van der Zee study, they show that this occlusion will get back to normal within 10 days to 2 weeks. So it's a temporary. You need to inform the parents and the child that they might have some open bite and some discomfort from the pressure initially, but that's all temporary. Within 1 day or few hours, they will get used to the changes in their dentition. So here I'll show you now some statistics, because if you go back to what we have discussed initially, that about whatever we do, it should be evidence-based. And for me, when I heard about the whole crown initially, I accepted it. Why? Because I found that there are some studies, they have proved their success and the success rate. So there is no point of me rejecting the idea of the whole crown, because it's a controversy. Some they say, how come you leave caries lesions under the crown? Maybe in 10 years back I would have think this same way, that how come I leave a caries under the crown without removing it? Yes, but studies have shown that if we cover the teeth, you will stop the ecology system of the dental caries, because there won't be any sugar reaching to the pulp. The pH of the cavity lesion will change because there are no any kind of active caries lesion in their area, and because of the fluoride in the GIC, this might help us to either arrest or remineralize the caries lesions, and it will stop at that level and it will not proceed. Okay, yes. Dr. Hiba, she asked here about the increases of occlusal vertical dimension. Yes, we mentioned that there will be an occlusal increase in the vertical dimension, but that's temporary, and you need to inform the parents, and you should not do any other whole crown until you wait for the occlusion to settle down, and then you can proceed with your next. So looking at these statistics now, the red ones are these for the whole crown. So here they compare the conventional restorations, like class 1 and class 2, like conventional restoration with the whole crown. You can see in the whole crown, they had one case of having pain as a failure, and in the conventional, 11 cases of pain were reported. As a major failure, which is like tooth become necrotic or abscess, here it's only 12 in the, for the whole crown, 13 for the conventional, which is still much less, and minor failures, 5 only it has in the whole crown, and in the conventional we had 45 minor failures. So let's have a look at how the child has accepted this kind of treatments, and parents or carer accepted, and dentists accepted which kind of treatment. So if you compare, 95 have accepted the whole crown, 28 conventional. So this is from the child. So the child, as you can see, children, they really accepted having a whole crown instead of having the conventional treatment with the caries removal and local anesthesia. And even the same with the parents and same with the dentist. So you can see that the statistics, they show that it's the first choice for the dentist, parents and child, and they highly accept and they are satisfied with the whole crown. So whole crown, it's a technique in our toolbox. So we as a dentist, we have our toolbox. We have different kind of treatment modalities. We have different materials to use, and none of them has like negative points over each other. So the thing is that when we use it and the indication of using it, so we have all this material, and we should be like in dentistry, we have every day, we have some innovative material, some new techniques which we can use. We should not like reject whatever we hear about something new. We should as well, we should accept what these treatments. So we have in our toolbox now, we have the whole crown, but we should be very smart, and we know when we need to use this whole crown, which will be benefit for the patient and for the child. So let's summarize now what we have taken. So to give you like a better idea about it, better evidence base, Benihani from the Leeds Dental School in UK, she did have a PhD dissertation on the comparing the biological approach of the. She compared basically the conventional stainless steel crown. She had 428 teeth. They were conventional approach of doing a stainless steel crown, and 408 teeth with using whole crown. So basically, she compared at the specialist level the success rate of different factors of success rate of doing a conventional stainless steel crown, which is preparation and crown, and biological crown, which is no preparation and using whole technique. So if you look at the cost effectiveness, biological, the mean cost was £79, and conventional cost, it was 168. So it is cost effective. And is this, so yes, it is cost effective, and she found out the success rate of doing a stainless steel crown with two ways, which is the conventional technique, doing preparation, and using biological technique with no preparation, using the whole technique. Both have the same success rate. Success rate of the biological arm, it was 95.8, and conventional treatment, which is here in this case is a stainless steel crown again. So both were a stainless steel crown. This was done with preparation, and in this case we have with no preparation. So the success rate are almost equal. Both are 95%. But the other things about the whole technique or biological technique, it's more cost effective. So here it's another also the recent article. Hit outcome of the 23 month. Also they have published, and here you can see the whole crown. The clinical failure, we had 2 cases only, and both clinical and radiographic, which is a gold color, it's only 1 case. And if you look at the control restoration, which they were 124 again, we had 12 cases of clinical failure, 5 cases of clinical radiographic, and 2 cases of radiographic failure. So statistics have like, they now every day we have randomized clinical trials, systematic reviews. They all show that the whole crown is really effective and has very low failure rate and high success rate. And we have the evidence to support it. So there is no any way of rejecting this technique and not having it in our toolbox. So scientific biological approach. So both treatments are equally good. This is they found that doing conventional stainless steel crown or whole crown, both are fine. But you need to have a proper case selection, and you should have a scientific biologic approach. Not any biologic approach. It should be scientific, and it should be well evidenced. So a lower number of the GAs, they found that in the UK in 2015, they the State of the Children Health in England, they found that by having the whole technique in their toolbox, they have lowered the number of the general anesthesia for pre-cooperative children. And same we have here in our hospital, in our university, we found that we have saved many children from going into the general anesthesia. Although general anesthesia is safe, but it's always our last option to decide to go for general anesthesia. But whole crown and having, as you can see, all whole, we call it, like when you restore all the cavitated teeth with the whole crown, they saved many children by undergoing general anesthesia. So how can we achieve this? By correctly assessing and maximizing the prevention. As we said, no treatment can be successful with no prevention, and manipulating the environment, which is we seal the teeth by GIC and the crown, so the environment will be manipulated for the cavitated lesions. So this is a whole crown. We have 3 years follow-up. So this is a case that I showed you initially. We have the 3 years follow-up. Initially, patient came with cavitated lesions. We place the separators, we place the whole crowns on all the teeth, and here you can see after 3 years, teeth are intact, crowns are intact, no furcation involvement, and no any kind of abscess, no pain. Patient is happy, and we are happy. So for prevention, if you want to read about the prevention, here is the toolkit from the Department of Health in the UK. You can find it also free from the Google. It has all this information about the prevention for children and adults. So dental caries, should we still drill? Yes or no? It's now your decision. So we have these options in our toolkit. So should we still drill? The answer is yes. We still need to drill, but where we feel it is of overwhelming therapeutic value for the patient, challenge your conventional dogmas. So we have the whole technique now in our toolbox, and we need to be very smart in selecting the cases. So I'm happy now to tell you that this whole technique has been added in the toolbox of the dentist. You don't need to have all these kind of instruments in the street. By having a whole technique, only sensitive crowns and the GIC luting cement, you can save all this and have a good restoration and happy children. So in conclusion, as we say, we should not accept any treatment, or we should not do any kind of treatment without having any evidence. So for the whole technique, we have enough evidence to support its clinical success. Thank you. So we'll move now to the demonstration, and I'll show you how can we do the demo for the whole crowns. Okay, so basically, as we said that, okay, what can cause this technique to fail and how to prevent that? Yes, I was about now to tell you that the main failure for these cases is that you have a wrong diagnosis of the pulp. If you are not sure of the pulp health, don't do whole crown. If, like, I give you an example, you have a very deep cavity, but you have a very thin layer of the dentine covering like very layer of dentine which is a bridge between the pulp and the cavity. In these cases, how can you make sure, and especially in children, they are not reliable in doing the giving you the signs and symptoms. Every day they come and tell you. So the best, which I do practice, that if I have a very deep cavity, I place it, if it is asymptomatic, I place a GIC in the cavity, I seal the cavity with the GIC, and I wait for 1 month. If the tooth stayed asymptomatic, that will give me an indication that the pulp is healthy and there is no any infection or inflammation in the pulp. So the pulp status is very important. If you have very thick, clear band of dentine and the cavity and the caries is still within the D1, first layer of the dentine, then most probably the pulp is healthy because it's away from the pulp, and you need to have a radiographic. It will give you most probably the sound radiographic appearance. But most of the failures, it comes by wrong diagnosis in placing whole crown in a very deep cavities. So if you are not sure of the pulpal health, pulpal status of this teeth, then best is to place a GRC and wait for 1 month minimum. And if the tooth stays asymptomatic during this 1 month, then you can place the whole crown on top of the tooth with the GRC. Let's come back now. There's one more question. Should the whole technique be used by GDPs or a specialist? This is where it's. I don't have a clear answer for this. I mean, studies of the doing whole technique, like Benihani, when they compare the whole technique with the conventional, they compared at a specialist, pediatric specialist level, they found that it has a better success rate. And studies where they were done on at the GP levels, they found that the success rate reduced a bit. So I'm not sure if under the undergrad for GPs there is enough training. Because as far as I know, in the UAE here, we don't have training about or they don't take it maybe to the curriculum about the whole technique. Maybe if they take a good training and they practice it more than like for a while in the undergrad, it might be a good option for GPs to use, because that will save the patients time and will give them better experience of the whole technique in general. So, but I don't have a clear answer for that. I'm not sure if I should say yes or no, but for me the answer most probably for now it's no, until we make sure that there will be a good teaching curriculum about the whole technique in the undergrad, then they can use it. Okay, so let's look at this model now. Imagine that you have a cavity on the occlusal cavity, as you can see here. So, and if we want to try the crown on this tooth, most probably it will not fit, because why? Because you have a contact between the teeth. So we have a contact between the teeth here. Let me get the Explorer so I can show it. Yeah. So as you can see, we have contact point here. Here it will not allow the crown to go in. So and we cannot do preparation because it's a whole technique. It's not a conventional. So we have a cavity here, and we want to whole crown it. So the best way is to create the space with the orthodontic separators. These are the orthodontic separators. I put it here so you can see it clearly. Yeah. So basically, how we do it? You pass two floss between the separator. This is one. And here we go. This is the second one. So when you have two floss, this is how it looks like. Okay. So you stretch the floss, and you pass it between the teeth, but make sure that this separator is around the contact point. Let me draw it for you, just stay. Okay. Imagine this is a contact point. This is a contact point between the two teeth. So make sure that, like, here is one tooth and two adjacent tooth, and you have a contact point. Imagine that you have a contact point between two teeth. So make sure the separator, it just goes around the contact point and not below the contact point. It shouldn't be below the contact point. It should be, as you can see here, the separator, orthodontic separator, is passing around the contact point of the tooth. And it's not below the contact point, because it will be hard to remove later on, and it will cause inflammation. So here, as you can see, it's passing nicely around the contact point. So once you place this separator, you remove the floss, and for example, for this case, you don't need to place here, because the separator, even if you place a separator, it will not stay because you have a spacing. But imagine if we want to do a whole crown for the E. In this case, then we need to place another separator on the distal side of the E, because the 6 is already erupted. Yeah, so again, make sure that you don't pass the separator below the contact. So these are the plastic ones. Oops. Yeah. So this is not perfect. It shouldn't be that way because this is a plastic. It's not really ideal, but it will look like something like that. So you have two separators between the mesial of the E and distal of E in case that you want to do the whole crown on the E. Yeah, how long shall we place the separators? Separators, you can, sometimes we might place it even for 1 hour. We might get some results sometimes, so we place the separators and we'll ask the patient to wait outside in the playing area, and after 1 hour we call the patients back in, we remove the separators and we get the space. But that's not ideal because not always the time you will get a space, but sometimes you might do that. But 1 day might be enough, 2 days might be enough, but up to not more than a week you should be there. So if you place today, make sure that you see the patient next week. So not more than 1 week the separator should be there, because you know that these are the foreign materials and will cause more plug retention and will cause some gingivitis around it. So once you place, you will wait for, as we said, 1 week, and then patients come back and you do. You can, okay, you imagine that you have the patients come and you can do a whole crown on this side, and you can have another whole crown on the same visit on the other on the left side. So you can have a whole crown, for example, for instance, you can have a whole crown for the lower E or an upper D. As long as it's on the other side, you can have 2 crowns on the same visit. But make sure you don't have two adjacent crowns with each other, and you don't have 2 opposing crowns on the same visit. So we send the patient back home with the separators. Patient come back, and then you remove the separators with the spoon or with the explorer. Yeah, we remove the separators. So definitely, since it's a model, we cannot have a spacing, but imagine that we have some space between the mesiodistal side of the crown, and then once you choose the crown, choose the proper size of the crown by looking at the tooth, and imagine that if you push further, that the crown will go in. So that's very critical to choose the proper size of the crown, because it's very common to have. Sorry, I pushed it too in. It's very common to have an oversized crown, and especially for the E's, if the 6 is not erupted, if you have an oversized crown on the E, distal margin will be too like you have an overhang. So that might affect the 6 to become ectopic, and it doesn't allow the 6 to erupt fully. So make sure that you have the smallest that it fits the tooth. You choose that crown. So by looking at this, this is how you should try the tooth. You shouldn't push it fully. So by looking at this now, we have an idea that if I push it further, this crown will go in. And always it's good to have with the crown pushers. So once you choose your crown, you will fill the crown with the GIC, and then you put your crown and then you push it in. You press it from all over, and you make sure that the crown is fully seated. And then you can put a cotton roll here and ask the patient to bite on a cotton roll and remove the excess cement around the crown. So as you can see, now in this case we have a bit of other bite, open bite, and because of this crown is longer, because we have not done any kind of occlusal reduction, but that's temporary. It will stay for around like 10 days, and after 10 days the occlusion will be back to normal, and this open bite is always noticed after placing the whole crown. So basically we did not give any local anesthesia, we did not remove any caries, we did not do any restoration. The key is to select the proper case which is indicated for the whole crown. Pulp should be healthy, there shouldn't be any infection or pulpal inflammation. And once you diagnose the tooth as being healthy, and then you can decide the child needs to go for the whole crown. But if you are doing a quadrant dentistry, again, whole crown is indicated when it is indicated. When it's indicated when you cannot do your conventional techniques. So conventional technique, it's what we have always used to do that. So the conventional technique, you do it whenever you do a quadrant dentistry, which is very common in pediatric dentistry. We give like block, we put a rubber down, we do fissure sealant on the 6, pulpotomy crown on the E, and a crown, for example, we do conventional crown on the D. So this, in case of the quadrant dentistry, then there is no point of having if you can't do your conventional, then whole crown might not be an option, but still it can be an option if you prefer. But if the child will definitely needs an injection or local anesthesia and to do pulpotomy on the adjacent teeth, and you will going to numb this area, so there is no any point of doing the whole crown, and on the adjacent tooth you will give local anesthesia and do the conventional technique. So if you can do conventional, do your conventional in the proper way, and whole technique is always there in your toolbox, will help you to do this kind of restoration for anxious patients, for uncooperative patients, and for the pericooperative children. I commonly use the whole technique as kind of the behavioral management technique to acclimatize children to the dentistry. So that's a very easy, simple way to do a restoration, make them happy, and tell them about where you're going to have your like iron tooth, your helmets or something. So it's a good way of introducing children to pediatric dentistry or to dentistry. But as we said, if you can't do your conventional, you have all the options to do. So this is the whole technique. It's in our toolbox. We always use it whenever it is indicated. So any questions? So wait for 1-2 minutes if anyone has questions. Make always, whenever you place the whole crown, make sure that you floss between the teeth after placing the whole crown to remove the excess cement. Because in many cases we see that the patients come back with the gingival inflammation because of the excess cement which is left. So make sure that you floss between the teeth after doing the whole crown. So that's all about the whole crown. So to summarize, we have 2 minutes. Whole crown is a biological technique to arrest, which arrest or demineralize the caries region, and to stop the caries activity in cavities which have not reached to the pulp and did not cause any kind of inflammation to the pulp. So, and it's very child friendly, and it can be used as a behavioral management to acclimatize children to the dentistry, and at the same time, which is very important, to save the precooperative children from having treatment to be done or full mouth rehabilitation under general anesthesia. So thank you so much. I'm open for any questions or you can always email me, text me. Yes, thank you. These are my contact information. Whole technique, and if you want the articles, or if you want the guidelines or the toolkit, I can always provide them for you, and I'll see if it's possible to put them online for you. Cheers, thank you so much for listening today, and hope to see you soon again. Thank you so much.